Things have been great. Selfishly, we just like to hang out.
Yeah, there's really...
We do this assembly so
the fact that we educate people is really secondary to the fact that we just enjoy each other's company. So that's...
And you bring in, Sacchetti and the crew, it's just a great time. So honestly, and a lot of our participants, a lot of the audience are individuals that have come year after year, and also, I think enjoy the networking, and that is what in-person conferences are about, right? Like the content isn't going to be dramatically different. It'll probably be the same whether you are in person or watching it virtually. But I think the engagement, the ability to actually have learning in between, because the number of questions that we field outside the conference are too numerous to count, and is actually where all the fun is. It's fun.
I think that you mentioned, Ryan, that COVID really kind of hit all in-person educational topics dramatically hard, right? And PEM Assembly was no stranger to that, especially with what happened with the New York meeting. But we have slowly gathered, the group again, and as much as we've had people who've been coming for years and years, we're getting the next generation and the people who are asking those questions. Whether it be during the question and answer sessions or actually just off to the side and just having that conversation. And I really do think it's that approachable aspect that we bring to this discussion, as well as any ASAP conference, where you can have that conversation with a Sean Fox, with a Marion Gaucher-Hill, with the big names of our world that I am but a peon to. But the reality is that you're talking to the experts, the people who on shoulders that we are standing on, and you're just having a conversation like they're a normal person, because we are normal people. Yeah. Or they are. I'm not. So.
You're definitely not normal.
No,
far from normal.
Yes, that's exactly right. I've got MS5 diagnoses.
Well, that's fine. We talked about it. It works well with the children. You talked about the differences in the evaluations of children versus the things that don't play well until the patient may be back in diapers once again with age-related, the jingling keys and...
Yes, again, adults really frown on, who's a good boy?
The dinosaur on your stethoscope.
I think that, we are fortunate. I am fortunate that I work in the greatest specialty, caring for children. And a lot of emergency doctors will be like, I'm fine with the kid. It's just the caretakers that are a little bit more draining. But you win the child, everybody else in that room just is with you. That's the beautiful thing about it.
I honestly, every aspect of everybody's job, regardless of what it is, has some negative attributes.
Sure.
So we could never steer away from, all pain. Like, there's going to be pain points in everything we do. And yes, parents, me being a parent, I can say this, can be a pain in the rear end. But I look at that conversation that I have with maybe a challenging parental encounter as being an opportunity for me to, get some guidance, give some education, and I know the reason they're there is because they are caring for the same person I'm caring for. So we actually 100%. Are on the same team. We just got to spin the story around. So we're colleagues helping their child versus adversaries, and there's a number of strategies to pull that off. It's more challenging for me sometimes dealing with the 22-year-old who's in the emergency department who has runny nose, cough, and a sore throat, and you're like, have you ever felt this way before? And they're like, no. And you're like, really? You've never had a cold before. We need to obtain all of your DNA and figure out what is unique about you.
Finally, the cure to the common cold is in your blood, young man.
So sometimes those conversations I have a harder time with, but it's an understandable, people being a little reluctant to engage with parents. But I think if you look at them as potentially a colleague or a teammate that helps you care for the kid. Hey, I know I can send this kid home tonight because I know you're going to do an awesome job of keeping vigilant eyes on them, right? Just win them over. There's some strategies there, but the fact that we are, regardless of where you're seeing the kids, whether it's in a large city or no city. Like, the whole purpose of you and I existing, really, I think, is for us to make sure that our colleagues across the country are able to deliver that same excellent care to every kid, whether it's with all of the resources or no resources. And the beautiful thing about taking care of kids is, honestly, most often you don't need a lot of resources. You just need good history, good exam, and being vigilant for the things that you're like, oh, that's different. We need to be a little bit more cautious with you, right? Whereas the adults, as we talked about today, as like the adult comes in with a chest and says they have a chest, and all of a sudden we got to order a bunch of things, right?
But I think the anticipatory guidance is a little bit more important in the care of a child. One, you're never going to, as a parent as well, you're not going to answer all the questions, right? For a father, you probably have. For a mother, unlikely to do so. But the reality is that you're going to talk about the what if scenarios. You're going to talk about, if Johnny does this, something as simple as falling from standing and hitting their head. It's a horrible noise for any parent who's heard it. But by the same token, we know, based on our experience, based on the literature, based on our practices, that the likelihood of anything significant other than, yeah, that sucked, I'm so sorry, and a little bit of ibuprofen along the way, there's going to be very few things. But if that kid has an episode of vomiting, they're going to freak out. So you have to have that conversation. So I do think that peds might have a little bit more experience with that kind of letting them know what to happen next, as opposed to the adult world where really exsanguinate them and send off the labs.
It's certainly more than return precautions.
Yeah, no, I
right.
agree.
It is, and I honestly think I steal a lot of things from my adult practice to my kids, and I steal a lot of things from my pediatric practice to my adults. And one of the things I steal is actually being a little bit more inclusive in my discharge conversations I have with families, whether I'm talking about a 2-year-old, a 20-year-old, or a 60-year-old. I do think about anticipating what it is we may, because hey, you're an otherwise healthy person and you came in with chest pain and we got an EKG and it's fine, your chest x-ray is fine, you have very low risk, your heart score is a 1, we can safely send you home. But I do want you to not just come back for X, but we might be dealing with something else, and maybe I am overlooking something, or maybe this is just the beginning of the story and we haven't read enough of the chapter to figure out where we are in the story.
Evolving.
Things are going to evolve. So, but that's anticipatory guidance.
Yeah, no,
right?
you're right.
That is something we steal.
But it's funny though. I think that most parents would absolutely, their arm is taken off by a thrusher, but their kid has a runny nose. I'm taking my kid to the pediatrician. Don't worry about the arm. We'll get to that later, kind of thing. So, there is some altruism out there that is special to the pediatric population that we don't necessarily experience for ourselves when we are in dire straits.
No, and that is being able to tell, no matter the age, but especially with parents, this is what you're going to experience.
Yes.
Especially, like, let's just say roseola and phantom, one of those, just like, hey, a couple days, this is what's going to happen. Of these things, of saying what they're going to experience, so when it happens, they're like, oh, he told me this was going to happen. And so they're not freaking out, understanding that, with chest pain, that it's going to continue, or people who, right now with the viral syndromes, that they are going to potentially have some sort of chest pain. Yeah, and it's going to be around for a while. Yeah, especially when they come back in and say, I've been on 3 rounds of antibiotics, and the cough is getting no better. I mean, I'm right now just getting over my little flu A that I had for Christmas, and my little cough thing going on. Yeah.
Congratulations for that, yes.
Well, I did my 6 out of 7 shifts, 6 shifts in 7 days, including through the 26th. And on the 25th is when I first started sneezing and getting the runny nose, and I was like, okay.
We are kindred spirits. I had the same, all of my shifts, I work half my shifts on the adult side and half on the pediatric side. All of my shifts for Christmas block were in the PEDS. And I was feeling really great. I wore my super mask the entire time, but on the last half of my last shift, I was like, they got me. I don't know where they got me, but they got me.
They got me. So in my type of ED, where I have very few, we got 10% pediatrics, but not as much. You can usually narrow it down to the kid, so that way you have a purposeful spike, an angled spike.
Full-on facial sneeze.
It's the one where you're like, let me look in your nose and mouth, and as soon as you go, and they just focused assault like a sniper.
Yeah.
Yeah, I do think we probably need to wear a full face guard.
You've heard of germ warfare. I mean, that's all it is. It's just sending a child out.
It's pediatric and elderly that
Yes.
inevitably the reflex to cough as soon as you look in their mouth is what they have to do.
On the other hand, you see adults and you're like, say and they're like, I'm like, I need you to actually say "ah" so I can see your posterior pharynx.
Yeah.
I'm not looking at your singing voice. I just need to see
The
your
top of
throat.
your uvula looks beautiful.
Right, that's exactly right. Your palate, your
Yeah,
teeth are
your palate,
fabulous.
that's
Did
it.
you have Invisalign?
That hard palate looks very hard. So tell me about some of the things, the cruise similar to even when I was, that first conference I went to, kind of dive into just a few things that you've seen with significant evolution. Of course, every single year is some discussion on how young can we actually ignore a kid's fever. For the most part. I mean, it's the 3 months, it's the 48 days, it's the 30 days, 28 days. Now seems like we're trying to push to 15 minutes after birth where everything's good to go.
You get one APGAR score, and then you're
One
done.
APGAR. Once your
That's
APGAR
it.
score
You're
is
out.
done, they are immune for everything. But what are some of the hard-hitting things like this particular conference that you feel are kind of changes in the practice?
I mean, you designed today, so I mean, I think that you have a finger on the pulse of what's most important for everyone. Those who daily taking care of kids versus those who are do it very rarely. So I think that the last lecture about the Phoenix score is enormously important about just the recognition of sepsis and being much more fastidious about what you need to consider in all aspects. Age, doesn't matter. It's just really what are the vital signs? What do I have to consider? So.
Yeah, I mean, the really lovely thing I think about this conference is it is designed to be as inclusive of the practitioner's experience. So if you see yourself as a pediatric emergency aficionado and are looking to dive deeper into the Phoenix score, well, Dr. Emily McNeil is going to give you some great insights onto that. But also, if you are someone who, we're not going to say scared, but have trepidation about seeing kids, maybe pediatric experience or the patient encounters are lower on the number of patients you see per day, and you just want to make sure that you do have an understanding of what you're supposed to do for bronchiolitis, what you're supposed to do for croup. Our ability to kind of quickly cover some of the basics, some of the essential things. If you see a kid today, you should know how to take care of bronchiolitis and croup and those things. But at the same time, be able to broaden your scope a little bit and touch on, hey, we're not just doing sepsis the way we did, 2 years ago. The Phoenix score kind of, changes our conversation a little bit, and then has its own pitfalls within itself. Like, it's really not terribly applicable to what you and I do up front when we're seeing the kid in the emergency department. But knowing about it helps me talk to my intensivists afterwards, right? And I have a general disdain for a conversation that goes with a consultant that I don't know what they're talking about, or they're asking me things that I'm like, what, Phoenix? So the lovely thing that we've been able to do is kind of give, I think, a broad scope of everything where we are touching on the bread and butter, the core things that you need to know in taking care of a kid on a,
More broad spectrum.
in any environment.
Yeah, and I think that another thing that we've done is adapted our educational process so that the day of of a 50-minute talk is just gone, as it should be. Mm-hmm. So Sean created this year's as 15-minute and 30-minute lecture series, which again, most of us want to just hit me with the high points. What do I need to know? And that was ortho for me today. It was just 15 minutes, but that's probably all you need for the basic ortho. Whereas, the more in-depth topics, Tim Horeshko did an exceptional job on cardiology. And my two biggest nemesis are cardiology and probably endocrinology. I hate those particular fields. But bringing that same information in a way that's so much more absorbable and meaningful to the person who does it every single day versus the person who does it, once in a blue moon, it resonated with me just because it was so well done.
Yeah, I mean, that topic, he was discussing subtle signs of heart failure in pediatric patients. Right. And I mean, talk about a, fear-inducing, thought process of, dealing with the child that is in fact presenting in front of you with heart failure, but they have, GI related symptoms. And like, how do I pick up on these things? And that gets back to the fact that, in pediatric patients, remaining vigilant affords us the ability to actively look for signs and symptoms and ask appropriate questions and build our, getting back to our core principles of everything that we do should be founded on our history and our exam, because kids don't come in with a lot of comorbidities. Like I can make major medical decisions based on my history and exam. Again, the adult has diabetes and hypertension and hypercholesterolemia and has smoked forever, and they come in with a chest and they say they have a chest, and therefore I have to do a bunch of things. And the pediatric patient, I most likely am going to be able to say the kid is fine, but I need to actively look for, do we have edema in this kid's butt? Like, this kid should not have butt edema.
My goodness. That is a very rare sign.
That's a very rare sign.
That's the pearls that you get here at the PEM
Please tell
Assembly.
me I do not have to start checking butt edema in my
I have
elderly
been
patients.
on GLP-1s for years for butt edema, and it has not worked out well for me either way.
Those are the things you learn here at the PEM Assembly. Butt edema. Take that home.
Or snot factory. That was
Snot factory.
And
Snot
we
factory,
also
butt
had
edema.
a metabolic acidosis is better tolerated than death. So
Yes.
we have quips like that.
I mean,
These are-
Dr. Rose is...
She has her finger right at the ready edge for care and of the sick child.
Well, that's the other thing, too. I mean, with this one, why you need to be in person, because you get the raw actual presentation before some things get edited out.
Yeah.
I mean, I'm not, like, for this podcast, butt edema is going to make it. That's not a problem.
We would hope that would be,
Yeah,
that's the
that's
leading
gonna
name
make it.
of the podcast.
But, there are certain presentations that we've had that, sometimes a little bit of the actual character gets edited out. Now, one thing I've noticed here is that it's almost like instead of a lot of conferences where you have kind of this shotgun approach to topic,
Random
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 stuff.
topics in
It's
random
almost
order.
a block schedule.
Yeah, we tried to again set it so that the themes would allow you to almost be able to take those two 15-minute talks and make them make sense in the greater context of everything. So for an infectious disease talk, yes, it is a more critical conversation to talk about sepsis and how we are maybe going to use or not use, or the pitfalls of the Phoenix score. That's gonna be a 30-minute talk. Like, in order for someone to be able to deliver that and have meaningful content come out of it, that should be a larger chunk of time. But talking about the how we evaluate pediatric fever, our favorite conversation to have. Honestly, we could do it in 5 minutes, right? Yeah. But we're kind to our presenters. We want them to come back, so we give them 15. And so from a thematic standpoint, we are able to still cover the bread and butter in a little bit more concise way,
right,
and make it still make sense in the context of the whole story that we're telling. So hopefully people will view it as, in my mind, it works, but we'll see.
No, I think that in conversation with the attendees today is that they recognize that it is almost like a 1-2 punch with the shorter version, and then the 30-minute that just brings it all together in a way that is digestible and that they can utilize in their own daily practice.
Well, you do look like today there was a fair amount of airway related conversations, the bronchiolitis, the
Asthma.
I'm
the token
CHF.
asthmatic.
Yeah, the token asthmatic. You
He
get up
does,
there
he does
and
really,
wheeze.
he does really wonderful impressions of
That's right.
respiratory,
Right.
not just distress, but almost failure.
That's-
in fact, in the back.
I'm actually in respiratory failure as we speak. I have halting speech.
He actually got the blue lips and everything. That was well done.
It's just the pallor.
Yeah.
It's kicking
Yeah,
in.
he's so hypoxemic, his words are starting to slur.
Right.
But there seems to be tomorrow, looks to be starting off with a fair amount of seizure-related discussions, status epilepticus. Looks like getting into Thursday, we're doing some of the neonatal based topics. With the selection of these topics, the themes, what makes you, with the full breadth of pediatric emergency medicine, these are the things that we need to talk about this year, because we've got, say, 3 days of content. that we are going to do these 6 themes. I mean, there's a little extra stuff. But
Yeah, I still think about it as if you're working in any emergency department, what are the highest probability of things you're going to see? You're going to see a kid who's injured. 100% you're going to see a kid who's injured. Now, that may be orthopedically injured.
Sure.
Or it may be, as we'll talk about tomorrow, traumatic brain injury, leading cause of death in children. And so you also, if you're working in an emergency department, going to see somebody who has a viral illness. And so Dr. McNeil actually discussed, that was the first thing we talked about today was, are you getting RSV testing? Are you getting, COVID and flu testing? And what to do to mitigate the potential challenges of those conversations. So, it was structured based on if you're going to see kids in an emergency department, whether you're at Ivory Tower or if you're at a place that has a very low pediatric volume, and what is the greatest probability you're going to encounter those conditions. So we touched on, subtle signs of heart failure. We did not dive into the post-op congenital heart kid, but it is the greatest probability that the first sign of myocarditis with the kid coming in with heart failure eventually is not going to be seen at the Ivory Tower. They're going to end up getting transferred there, right? So it's, in my mind, very important that everybody leaves here with essentially the same skill set of being able to be vigilant and look for those things that will have the greatest impact to be able to deliver excellent care for kids, to keep them as healthy as possible, because that's the ultimate goal.
Right, at the highest yield. I mean, that's really the goal.
And looking at these kids and saying, sick, not sick. I mean, your most important thing up front for us in the community-based hospital is walking in and everybody just say, okay.
I think that 90% of what we do is when we walk in the door, right? If the kid is running around the room, pretty sure we're going to be okay here. If the kid is laying, somnolent on the bed and letting people poke at him, that's probably a bad sign. Again, medicine is good or bad. That's really it. But yes, what Sean was saying is just hitting the highest yield topics to let people go forth and hopefully talk about what they were exposed to, share the slides that we have provided, and then we go from there. And I've always responded to any email that's come in, weeks or days or even months later in terms of, I'm still confused. What does that mean? So, I think that's the other thing about approaching us in person is that you now know me. I'm yours forever.
Okay.
I'm like a Labrador retriever.
So there actually was a study that showed our ability in the emergency department to discern sick, not sick in pediatric patients was like a really fundamental and was fundamental not just in our care, but actually we were really good at divining who needed us to do more for them, right? So our gestalt, which is really built upon all of our experience and our knowledge, we should trust. Now, I temper that with as long as you're vigilant,
Right?
Because we can get cavalier, we can get, and when it's flu season, good Lord, like.
Right.
We have extra strategies for putting the people out in the hallways and lining them up and just like, you have a cold, you have a cold, you have a cold. I still have to, browbeat myself to say, you just need to make sure you're still doing a good exam. Right. You still need to ask the right questions. Doesn't mean I need to God forbid I order any, viral testing, but I do need to do my job still and be vigilant and look for those subtle things. Which one of these kids here is not like the others?
Is tachycardic, out of proportion than what we should accept, or is more somnolent than it should be. Again, those subtle clues that you keep talking about being just cognizant of are so crucial. And that's not just peds specific. I mean, that's any ER doctor, that's any clinician, right? Is always thinking about what's the worst case scenario. But I think that we're a bit more jaded than potentially the rest of the world just because that's our job. Our job is looking for the problem at all times, which is honestly why I don't think I'm invited to a lot of parties. But that's a completely different conversation.
Is that because you are the problem?
That's probably
You found
true.
the problem.
I am the problem. That's right. It is.
No, he's
it
not.
is. I'm looking inward.
I mean, you got to get that nice little puppy dog look, like the Labrador
Right,
thing.
right.
Just
If
sit there
I could work on that.
yeah, fair enough.
But we'd mentioned, it might have been the time I interrupted you guys long ago, that the notion that pediatric patients aren't little adults is propagated over and over again. And I think one of our challenges is that statement.
Yeah.
Because it has, for a millennia, engendered fear. Now, it was born from a good point. It was born from the acknowledgement that there are differences inherent in the children's physiology and their anatomy. They have different anatomy and physiology. So while that is true, and I might not just be able to directly apply a management strategy for my adult patient to my pediatric patient, and I need to be aware of that, it doesn't mean they're an alien, right? It doesn't make them some otherworldly figure. No, like they are still human, and they are therefore a special population, but we manage so many special populations. We were joking about elderly patients, very special population. They literally have different physiology. Many of them will not have fevers when they're horrifically sick. Many of them have different anatomy because things have been removed from them. We manage patients that have transplants. They literally have both different anatomy and physiology. We give them medicines to make their physiology not work, right? No one goes, oh, I don't take care of transplant patients. But we've engendered with this notion of kids aren't little adults in a group of our colleagues that we're like, kids are weird. They say kids aren't little adults, and we then can abdicate responsibility. Well, if you are working in a large quaternary referral center, I guarantee you there's people there are happy to see the kids for you. That's fine. But across the country, that's not true.
No.
Kids aren't going to the large quaternary center by and large all of the time. The vast majority of kids are going to see all of our colleagues out in the emergency department in the community, and we can't have anyone abdicate responsibility for taking care of them. So I'd rather focus on what is it that are those unique features? What are those unique aspects that make them a special population? And then we just need to focus on them and learn them, just like we do for our elderly patients or our transplant patients or our cancer patients or any of our other patients that we take care of. Every individual, in fact, is specifically unique.
I think that the most important thing that we also need to remember, listen to the family. Listen to the caretaker, right? Growing up as a severe asthmatic, my doctor used to say to my mom, Mrs. Amato, you talk to a mom long enough, she'll tell you what's wrong with the kid. You talk to her a little bit longer, she'll tell you how to fix the kid. So if they're saying there's something not right with their kid, you just move on from there. And that's taken as gospel. The only thing I would add after 30 years of doing this is that I'm not sure that I would listen to the dad a whole lot. Now, I know this is being recorded, so I'm saying that tongue-in-cheek, people, okay?
But the dad has the mom on the phone.
That is actually true. That is actually true nowadays. I've spoken to more parents on FaceTime than potentially in person lately.
Yeah, and we get that all the time, especially with the kind of potential broken family, is like, so what's going on? What's the history? I don't know. I'm
just told to bring them here.
Let me get mom on the phone. You're absolutely right. All right, so as we wrap up today, I think the key, this used to be called the PEM, the Advanced Assembly. But this is really designed for everybody. What I got out of this as a community emergency physician, fantastic stuff. So give us, this one, not going to make it here this year because we're already halfway through, but we'll come up next year in Orlando. So a little pitch to bring, as we go back to kind of the roots of PEM Assembly in Orlando on the property for Disney, kind of give us the pitch for getting folks there.
I think that if you want to become more comfortable in being able to assess and manage your pediatric patients and know not just the first couple steps, but maybe the next 2 steps in addition to that, this is a great place to do that. Probably the best place, the best conference to not just listen to Dr. Amato or Dr. Sacchetti or Dr. Cantor or Dr. McNeil, all these individuals that are just phenomenal presenters in their own right, but collectively are going to be able to give you the science, but then insights into the artistry.
Right.
The artistry of pediatric emergency medicine and how to apply those different skills in different environments, I think, is what everybody's most hungry for. I can read a paper myself, okay? I can understand from a podcast or from online video on how I'm supposed to approach the 28-day child with a fever. But there's so many gray areas in all of that. What does the panelist have to say? Mm-hmm. And that's what we do, is we have the high-hitting topics, and then we gather the minds together and answer the questions. And that's my most favorite part. If we could just do a whole conference of all of us having conversations about how do you manage the kid who has eaten so much ketamine for their sedation, and ortho's like, I still need 20 minutes. Like, what do you do then? Like, I want to know, because I had that case. Like, what do we do? And being able to like see what Al Sacchetti does and what Ian Claudius does. Like, oh, okay, well, this is Monet and Manet. These are, people that are not just gifted clinically, but are gifted in being able to convey how it is they do their artistry. And now I can steal from them. Steal from all of them.
I think that's the goal, right? Residency is all about trying to figure out column A versus column B versus column C and what I want to steal from each one to become the physician I am. But that process is not
done.
It is not static, it is dynamic. And that continues throughout your course of care and being a clinician. So the other advantage of coming in person is I was just actually trying to figure out a problem for a patient, for an attendee who is in a resource limited location in Colorado, and when they have a really sick person and there's weather, well, then they're stuck in their ER for hours until such time as we can either get a rig on the road or we can get a copter in the air. So we were just talking about, a respiratory patient and how we can kind of brainstorm what we can do for that particular shop. You can't do that at a video screen. You can't do that unless you're talking to all these experts and to all these people who have far more experience and knowledge than I do. But once you bring that up, I got Tim involved because I know he's extremely intelligent and aware of the literature. So we brainstorm as a group, and that's honestly also the fun of this program, is that we're so approachable. We are, like I said, you email us, we shake our hands, or you just say hi. We're friends forever. Come on, kids, come on down to Disney. I promise it won't cost that much. Gosh, I think you're being goofy.
So we've got next year, January. No, that's this year. That's the 2026. Our next year, when are we going to be doing it? Do we know? Yeah, there we go.
I have a feeling it's the same time.
Yeah, January 24th through the 28th, 2027 at the Disney Coronado Springs Resort in Florida. Sweet. Everybody loves it. I mean, last year we were in Orlando, right, but off property.
We were
Orlando Disney adjacent.
Disney adjacent.
It was. I enjoyed it, but at the same time, we are on property again. 2027 Accelerate, January 24th through 28th, the Disney's Coronado Springs Resort. I would definitely recommend, if you've never done the PEM Assembly, to come and gather. It is as entertaining in person as it is just on this podcast. Even more so when Richard Cantor gets spun up. That's always fun.
He'll be on stage tomorrow.
So we may not record that, but we'll get to that first. It's fantastic. If you actually look back at any of our stuff that we've had together with Dr. Cantor and any of these speakers, fantastic topics. So make sure, put that on your calendar, January 24th through 28th, 2027. You contact me, rstant@acep.org, rstant@acep.org, at @EverydayMed on X, and make sure that you are subscribed to the podcast on whatever your favorite player is, so you're getting all of the weekly content, and latest while you're at it, a 5-star rating and a compliment on there to get us boosted up. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.